Caught early before it spread beyond the prostate, almost every man survives prostate cancer. The 5-year survival is basically 100%, and even 15 years out, it's still around 97%. But if caught late, once it's spread to distant parts of the body, that number falls to about 38%. Same cancer. The only real difference is when it was found, and which side of that line you land on has almost nothing to do with luck. Now, here's the part that should bother all of us. The men who die from prostate cancer almost never got the chance to catch it early. Most were never told how, and some were actually told not to look. And I'll explain what I mean by that in a minute, because it's honestly one of the strangest and saddest stories in modern medicine. But the good news is that your odds of ending up in that 97% are largely in your control, and I'm going to show you exactly how to stack those odds in your favor. So, in this video, I'm going to go over a blood test that you've probably already had, or at least heard of the PSA, and more importantly, how that one single number can fool you in both directions. So, I'll show you why a high PSA doesn't automatically mean cancer, and I'll talk about the everyday things that can make it go up. And then, on the flip side, how a normal or even low PSA can still be hiding cancer. And then, if your PSA does come back high, I'll go over the best steps, including imaging and new biomarkers that you can ask your doctor about to better quantify the risk and potentially avoid a biopsy. Because catching this thing early isn't just about surviving. It could often be the difference between a small limited treatment and then surveillance versus extended chemo and hormone therapy. And if you're new here, I'm Dr. Willem. I'm a double board certified physician, and on this channel, my mission is to give you the science and the practical tools to not only live longer, but to feel better today. And as always, even though I'm a physician, I'm not your physician. So, please talk to your doctor before making any changes to your health regimen, because this video is educational only and not medical advice. So first, let's start with why this cancer in particular is so beatable. Prostate cancer for the most part grows slowly and predictably. So unlike pancreatic cancer, which can spread before you even know it's there, prostate cancer usually gives you a window of years to catch it. The problem is that window is silent. Early on there are no symptoms, no pain, no trouble going to the bathroom, and nothing that you feel. So I feel fine means nothing here. Feeling fine is exactly what early prostate cancer feels like, and the only way to catch it in that window is to go looking for it. And prostate cancer is no longer an older man's concern anymore. It's actually showing up in the younger men and in more aggressive forms. So if you're in your 40s or 50s, this matters now and not later. And that brings us to the strangest part of this whole story. Because you'd think that for a cancer this common and this beatable, that everybody would be getting checked. But what happened recently was closer to the opposite. So, back in 2008 and more broadly in 2012, the main group that sets U.S. screening guidelines, the U.S. Preventive Services Task Force, recommended against routine PSA screening. They basically told doctors to stop offering it. And I want to be fair, because the reasoning wasn't crazy at that time. Back then we were finding a lot of small and slow cancers that were never going to hurt anyone, and treating them anyway with surgery and radiation that could leave men with real side effects like trouble with urination or sexual dysfunction. That was a real concern. So the thinking was, if screening causes all this harm, maybe we should pull back. The trouble is what they leaned on to make that call. So a big American trial called PLCO compared men who got PSA screening against men who supposedly didn't, and found almost no difference in prostate cancer deaths. Sounds like a closed case, but once they examined the data closer, around 80% of the men in the no screening group actually got PSA tested anyway. So, the study wasn't comparing screening to no screening. It was comparing screening to also screening, and of course, it found no difference. But here's what happened after these guidelines told doctors to pull back on screening. Advanced prostate cancer, the kind that's already spread, and the kind that pushes you toward that 38%, started climbing. So, now more men are showing up when it's already too late to easily cure. And when researchers went back and redid the math on the same trial, Correcting for all the hidden testing, it turned out that regular PSA screening actually cuts prostate cancer deaths by roughly a quarter to a third. So, let's talk about that test, PSA, because this is where knowing just a little bit changes everything. PSA, which stands for prostate-specific antigen, is just a protein that your prostate makes, and its normal job is to help you liquefy semen, and a small amount leaks into your blood all the time, and that's what the test picks up. And the key thing here is PSA doesn't actually measure cancer, but what it measures is prostate activity. Anything that irritates or enlarges or squeezes the prostate can push more of it into your bloodstream. So, I think of PSA as a smoke alarm. A smoke alarm is very useful, and you want one in your house, but it doesn't tell you what is burning. So, a smoke alarm can go off for a real fire, but it can also go off when you burn your toast. So, the PSA test tells you that something's going on with your prostate, but it doesn't tell you if that something is cancer. So, what can raise your PSA besides cancer? Well, quite a few things, actually. An enlarged prostate, which happens to almost every man as he gets older, and then prostatitis, which is just inflammation or infection of the prostate, a urinary tract infection can do that. And then recent sex or ejaculation can also bump your PSA by as much as 40%, which is exactly why a lot of doctors ask you to hold off for about 2 days before the test. And even riding a bike can do it, because the seat puts pressure right in that area. And a high PSA on its own usually isn't cancer at all. Of the men who get flagged with an elevated PSA, about 3 out of every 4 of them actually do not have prostate cancer. So, a high number isn't a reason to panic, but it is a reason to look closer. But you want to do the right way, and I'll show you exactly how in a bit. But we don't want to wave it off either, because that number can mislead you in the other direction too. And that's the part that often gets missed. There's a very common medication that can push your PSA down and make a real problem look like nothing. And this one is easy to miss for both doctors and patients. And the medication is finasteride and its close cousin, dutasteride. These are the drugs that a lot of men take for hair loss and for an enlarged prostate. And they're everywhere now, especially since you can get your finasteride online in just a few clicks for your hair. Finasteride can lower your PSA by about half. So, a man could be taking this medication and have a completely normal PSA even while a real growing cancer is hiding right underneath it. So, if you're on finasteride or dutasteride, a rough rule of thumb is to take whatever PSA the lab gives you and to double it to get closer to your true number. But the rule is not exact, and how much these drugs lower your PSA varies quite a bit from person to person. And it's also determined by how long you've been on these drugs. The longer you've been on it, the more they can mask it. So, we don't want to lean on that one number or that general rule of thumb. What matters more is the trend. And once you've been on that drug for a year, your PSA really shouldn't be climbing at all. So, any steady rise, even if your PSA number still looks normal, is a red flag we're taking seriously, and we don't want to brush it off. And in one large study of veterans, men on these drugs were diagnosed with cancer that had already spread at more than double the rate of men who weren't. So, about 6.7% versus 2.9%, because that early warning sign was masked. So, if you're on finasteride or dutasteride, just make sure that that comes up every time your PSA is checked. Now, so if a single PSA number can be a false alarm in one direction, and it could be falsely calm in the other, how do you actually use it? Because I don't want you walking away thinking this test is useless. It isn't. It's a very good alarm. You just have to know how to read it. And your PSA was never meant to be judged from a single number checked once or twice. What matters far more is the trend. Doctors call that PSA velocity, just a fancy way of asking how fast is your number changing. So, let's say one person has a PSA of 1.3. On its own, that tells you very little. But if a year later it's 1.7 and 6 months after that it's 1.9, well, that steady climb is a real signal, even though every one of those numbers is still technically normal. So, we want to treat PSA as your very personal trend line and not a single pass or fail score. And the other tool to reach for is imaging. So, if your PSA or your PSA trend looks concerning, the next step now is often an MRI of the prostate before jumping straight to a biopsy. The MRI shows you whether there's actually something suspicious in there, and it also lets you weigh your PSA against the size of your prostate, something called a PSA density. A bigger prostate naturally makes more PSA, so a higher number from a large prostate is a lot less concerning than the same number from a small one. So, between tracking your trend over time and using an MRI to look before you leap, you can catch the dangerous cancers early while sparing yourself a lot of unnecessary procedures, which brings us to the biggest decision point, the biopsy. Because a biopsy isn't nothing, and it could be a big deal. For a long time, it was the only way to know for sure, a needle into the prostate to take a sample. And the traditional route through the wall of the rectum carries a real risk of infection at around 5 to 7%. Plus, there could be real issues with bleeding and pain and discomfort. So, in these situations, the overarching goal is to figure out who truly needs a biopsy and who can safely wait. And the MRI does a lot of the work here when trying to decide when to pull the trigger on a biopsy. When men with a high PSA get an MRI first instead of heading straight to a biopsy, it finds more of the dangerous cancers and it catches fewer of the harmless ones, and it lets about 1 in from men skip the biopsy altogether. But a clean MRI isn't a guarantee. Even if the MRI comes back negative for cancer, about 1 in 10 of those men still have a cancer that matters hiding underneath. So, a clean MRI lowers your risk quite a bit, but it doesn't erase it. So, how do you handle that gray zone, a clean or a borderline MRI where the biopsy call isn't obvious? The most practical tool here costs nothing extra, and your doctor can already work it out, which is your PSA density. A lower number means lower odds that something dangerous is hiding, which can tilt the decision together with your doctor towards watching closely instead of going straight for a biopsy. And of all these approaches, it's the one with the broadest evidence behind it. But beyond that, there are a handful of newer biomarkers that can also be used. So, there would be blood tests like PHI, which is prostate health index, and the Furcase score. And there are some more urine tests as well. The one test that probably has some of the strongest evidence behind it is a blood test called Stockholm 3, and it is available in the US, but it's not currently FDA approved. In general, the current guidelines put these biomarkers at a lower tier or a lower category recommendation, meaning the evidence behind them is weaker, and there's currently no good head-to-head trials telling us which one comes out on top. But the overall strategy here is simple. We do want to keep getting screening PSA letters, and if a PSA signals a problem, well, the next steps are to get an MRI and to get a PSA density. Those things are a must. And because a clean MRI can still miss prostate cancer in up to 10% of people, this is where adding one of these biomarkers can be very useful to help predict cancer before a biopsy, or it can be an adjunct to help monitor a low-grade cancer for progression. Now, at the end of the day, the man who catches this early isn't lucky. He just had information that most men are never handed. Now, some of these biomarkers, like the blood test and urine tests that I mentioned, could be pretty expensive, especially if your insurance doesn't cover them. And I don't think many health plans do cover these tests, but the foundational pieces like checking your PSA and MRI should be covered by most insurance plans. Prostate cancer is one of the few cancers where if we simply use the tools that we already have, we could keep almost every one of these deaths from ever happening again. So, if you haven't already, talk to your doctor about when you should start checking your PSA, and then track the trend while accounting for anything that could be hiding it, like hair loss or prostate medications. And if your PSA does come back elevated, or if it's normal but there's a concerning trend, well, then definitely talk to your doctor about getting an MRI and how you combine MRI with some of those newer blood tests or urine tests. Alright, hope this was helpful. Stay healthy, and I'll see you in the next one.